Good evening, everyone. This is Nate Smith. I'm the Executive Director of the Sammamish Community YMCA. Thanks so much for joining us this evening. So excited to have you as we get the opportunity to learn more about the stigmas and misconceptions of suicide. This is our third in the 6-part series on suicide prevention that we're hosting over the next week. You can find our previous series on the website where those videos are available shortly. Tonight we have with us Ace Bolger, who is part of the Washington State Healthcare Authority, who is going to be speaking on the topic of stigma and misconceptions of suicide. Ace has spent the last 25 years working throughout the education system and has firsthand knowledge about this topic and has done so many different and amazing things over the last several years around this. And so I'm looking forward to what Ace is going to share with us and the learning that we're going to have. Throughout the presentation tonight, you're going to be able to put questions into the chat box, and there will be a Q&A at the end of the slide session. So if you put those in there, we'll be able to hold those towards the end, and then Ace will be able to answer those questions. So with that said, I'm going to pass it over to Ace to walk us through tonight's session.
Well, good evening, and thank you for letting me do a presentation. I'm Ace Bolger, and give you a little bit of a background as to why I'm here and what I'm hoping to accomplish. First of all, I hope there's something that is presented tonight that is relevant to you, that you can take away, that can actually help you if there's some area of suicide that you didn't know about, that there might be some information that you can actually apply. My background is that, as Nate said, I was in education for 25 years. I've done a few other things, but including being a certified coach with the Hudson Institute, but I never dreamt in my wildest nightmares that I would be involved with mental health. But 8 years ago, we lost a daughter to suicide. And so after several months of trying to recover and go through the grieving process, I began to research mental illness, suicide, depression, epigenetics, ACEs, and some other things. And lo and behold, I found myself fully invested and immersed, if you will, in mental health and suicide prevention. A while back, I was on some committees for the state on suicide prevention, one through the Office of Superintendent of Public Instruction, one from the Department of Health, and it turns out now Healthcare Authority. And I was, just as I am, just a private citizen. Now I am a coach, but I'm not speaking to you tonight as an agency representative. I'm speaking to you as a parent, as one of many hundreds and thousands of people just like me who have experienced suicide. And I just am fortunate and blessed to be able to take the experience that I had, my family had, and turn it in perhaps to something good for other people. So just want you to know also that on this, even though I guess you could call it a professional presentation, this is not something that I take around and say over. It's not a programmed presentation. I developed this specifically for tonight for the YMCA, and so it's unique to anything I've ever done, and you will not have seen it before. So with that in mind, I'm going to go over a little bit of the major concepts, key concepts that we would like to cover tonight. And these are really important. One of those things about addressing stigma is when we understand the complexity of mental health and suicide, it begins to dismantle the idea of stigma. Stigma, and we will talk about that a little bit later on, but stigma is really kind of a shaming perspective on anybody who might be suffering with mental illness. It's like, what's wrong with you? Pull yourself up by your bootstraps. Come on, buck up, go for it. But when you begin to realize the incredible complexity of how we're made and what happens with us mentally, that begins to destigmatize things. The other thing is the key concept is integration. The integration, as we have said, is a linkage of different differentiated elements of a system, but they're working together. And so we'll see that again and again tonight in terms of addressing mental illness and actually giving you some tools, some permission as to destigmatizing and also understanding the complexity, and even though some things that you can do to begin to integrate or help somebody else who is struggling to become integrated. And then we'll be covering stigma and resilience. Another key word a lot of you may have heard a lot. I'm not sure what other sessions you've had yet, but you may have heard of epigenetics and already been trained in epigenetics. I'm going to address that, and I'm going to do so within the idea of complexity and integration. And then we're going to talk about implicit and explicit memories, especially how that relates to integration and health and trauma. And we're going to look at some resources, some practical resources, and some practical strategies to apply just today, tomorrow, the next day. And at the end, we have a bibliography. And also, we have available for you as many resources, links, hyperlinks as you could possibly imagine. There's just tons of them out there. So if you would like more information, we will do our best to get it to you after the presentation when you let us know. So that's the overview, those concepts, and we'll come back to them in just a little bit. For me, the transformative process is that we hold on to things that we know are solid, that are evidence-based, that are practical, that are real, and we don't jettison those things when they're working for us. We hold on to those things, but there are some things in the transformative process that we have to let go of. And an example would be inaccurate information. And if we're behaving or living on information that is inaccurate, we really do need to let that go, but we also have to know what that is to let go of. The other thing is to take on, where maybe tonight you'll get to take something on from this presentation and add it to your repertoire that you decide you want to hold on with, and then ultimately you move on. That's a transformative process. And since we're talking about mental health, I love this one, be transformed by the renewing of your mind. I'll just say really quickly that when I learned about epigenetics and plasticity of the brain, I was going, aha, that's how we are transformed by the renewing of our mind. Our minds can actually be renewed. Next slide, please. So some questions for reflection. You know, as I'm doing this, remember now, I'm one of you. I'm a parent, and I'm just a citizen out there. And I'm now working with the Healthcare Authority, which is a relatively recent experience for me. But prior to that, I'm out there just negotiating the mental health system, just like all the rest of you. So I put myself maybe in your position before this webinar, and I'm going, I wonder what questions people might have. And so for me, and you can put this in the chat box, and hopefully we will be able to address those now or later. What do you hope to take away from this presentation? And an example would be someone is suicidal and asks for help. What do we do next? That might be something you're wondering. How do we know who to approach about suicide and mental health? What do you look for? What symptoms or behaviors? What caused the symptoms to develop in the first place? Is then suicide prevention a reactive policy? Or might we say that it's a responsive effort? Still, what are we responding to? And with the death of my daughter, we were really pretty darn close parents, but not perfect. And so when she died, you can bet, I looked and said, what did I do? What did I do wrong? How did this happen? How did I feel as a daddy? And those are some of the things that are the misconceptions of suicide that we can address. So there's a couple of minutes, or not even that, just a little bit. I have a next slide here that hopefully you can reflect on these things, and we'll come back to that after this next slide. So, because time is short tonight, when we talk about prevention, and as we were told when we began, this is the third of 6 webinars on prevention. So again, I put myself in your shoes, or even my shoes, and think, okay, what are we trying to prevent? Are we trying to prevent suicide? Okay. Are we trying to prevent mental illness? Okay. What are we really trying to prevent? And then let's suppose it is suicide. We have to say, what are the causes or the reasons for suicide? Are there causes then that we're trying to prevent? Gosh, wouldn't that be nice? As I say, if Humpty Dumpty falls off the wall and is broken, we can try to put him back together, but wouldn't it be better not to let Humpty Dumpty fall off the wall to begin with? And then there are things that you probably have heard. We'll talk about these a little more. If the causes are predictable results of adverse childhood experiences, so should our efforts be directed at prevention of adverse childhood experiences, or towards preventing suicide by treating and anticipating the effects of adverse childhood experiences? So in other words, we know that young people, kids out there right now are experiencing ACEs. So should we anticipate that and try to treat or deal with that right now, even when they're in the midst of experiencing ACEs? Very difficult and interesting questions, at least from my perspective. And then prevention might be proactive in the sense of anticipating mental health issues before the symptoms are manifest. And a little bit later on, I'm going to show you a slide and I'll bring that one up again. But that's the idea of prevention. And you might have some other things. What are we trying to prevent? I'm just trying to plug myself into an audience that I'm not really even sure who you are, and thinking maybe these are some things that they're wrestling with. So when we look at prevention, again, I was talking about the resources we could get for you. Well, there are a host of really wonderful national programs for suicide prevention. And this is Suicide Prevention Month. So if you get on the website, Google it, whatever, you'll find really maybe dozens of different national programs to address suicide. There are a lot of state programs. I happen to work with the Healthcare Authority, and you can bet that we are very much involved with prevention. And our sister agencies, the Department of Health, Department of Children, Youth and Family, DCYF, Children and Family Services, the Welfare Services, they have programs. OSPI, Office of State Superintendent of Public Instruction, and on it goes. There are a number of state programs, and within each agency, there are a number of sub-programs going on. And then resources. There are a number of resources, and I think you've already got some of them on the links from this presentation and also from prior presentations. There's a lot of stuff out there. And then we're talking tonight about stigma, demystifying behavioral health. And then we're really trying, and from my perspective, ultimately, it would be like to have a proactive approach. In other words, we're anticipating the effects of ACEs. We call that trauma. We're anticipating that. We know people are experiencing that. And then the new science discovery of epigenetics and genetics, how does that play into all this? And something that has been there for a while, but largely ignored, is nutrition and how that impacts our individual biochemistry, and even exercise, sunlight, and sleep as being absolutely incredible sources of resilience for people who are suffering from mental illness and suicide ideation. And then we look at networking, these cross-agency efforts. One of the things that is promoted through our national agencies and in our national, from one state to another, would be networking. It's really kind of tough to do because of what is called siloing, where people are doing really fantastic work in a particular agency, in a particular program, but they don't have time, they haven't developed the networks to know that another agency in another state or even in our own state is doing similar work. They just don't hear about it. And then we have the networking for individuals, and that's one of the things that I really try to promote is how to develop networks, because when I was struggling through the 7 years where our daughter was depressed and suicidal, I tried to create a network of all kinds of people, and it was really a very difficult task. And so now when I am meeting with people who have difficulties, I begin to share with them, you know, this is a task that you probably can't take on your own. You need a network of support of a variety of types. And we'll talk about that a little bit later on. So that's some of the overall prevention. It's out there. There's a lot going on. So, someone you love consistently shows signs and symptoms which cause you to wonder if something's wrong. You're not even sure. So what do? In our case, when my daughter was 14, she started acting like a 14-year-old. I was a principal. I was in a middle school. I had seen the changes of kids from grade school to middle school to high school, experienced it for years. And so when some of the things my daughter was doing, I thought, is this just her changing? Is this part of being an adolescent? But it was more than that. And actually, I had 3 daughters, and people were always saying, well, is it easier to have sons or daughters? All I can tell you is that other than my daughter's suicidal ideation, even in spite of that, my daughters were absolutely wonderful to raise. They were really not much of a problem at all. They were fantastic. So when Alicia started showing symptoms of things, it was like really kind of strange, and I wasn't really sure what to make of it, and I didn't know exactly what to do. But also, what would you want for yourself if you begin to experience suicidal ideation? Now that's an interesting one, because a lot of people will deny that they are depressed. There are certain biochemical type people who will be almost like a symptom of their depression is their refusal to admit depression, and of course refusal to get any help and refusal to take any kind of medication or really help. And that's a pretty large category of people who are depressed, and as you might figure out, there are a large category of those who end up taking their lives. But also, what would you want in order to help another who might be suicidal? And some of the practical things we're going to share with you tonight are just ways to really address somebody, to give you courage, permission to actually interact with somebody and ask them if they're thinking about taking their own lives. And what would you want to do, or how would you want to help somebody else who does that? And we'll talk about that a little bit more too. So what do we do next? That's the key question. The goal for those people who are suffering is to become resilient, to become whole, to become integrated, to be functional, to be happy, to be the best they can possibly be. And that's resilience, the process of adapting well in the face of adversity or trauma and tragedy or threats or significant sources of stress, such as family and relationship problems, serious health problems, or workplace and financial stressors. Well, let me guess here. Does that apply to almost everybody? Yeah. So how do we develop resilience? That's the goal. And sometimes we can't do it on our own. And this is really not too far-fetched. Developing resilience, how do we go? How do we do that? What's next? When our daughter was first admitted into Harborview Hospital, it was absolutely frightening, perplexing, agonizing, and we were in disbelief. Our daughter? Are you kidding? This can't be. So we get her into Harborview, and we were able to convince her to be admitted to the hospital. And she was in the hospital for 21 days before she was released. And as we were admitting her into the hospital, I very much felt just like this figure standing before a maze and going, what in the world do I do? And honestly, I had no clue. Now here's the ideal. Here's the ideal, integration. This is really powerful. I'm going to read it to you. This is what we're after. A system of care is a coordinated network of community-based services and supports that are organized to meet the challenges of children and youth with serious mental health needs and their families. Families and youth work in partnership with public and private organizations to design mental health services and supports that are effective, that build on the strengths of individuals, and that address each person's cultural and linguistic needs. A system of care helps children, youth, and families function better at home, in school, in the community, and throughout life. And that comes from a book called The Leadership Equation. It's right here. And the reason that I got involved with the Leadership Equation is because I started working for the Healthcare Authority, and it's called the system of care. Notice the very first sentence, a system of care is, and it just so happened that my youngest daughter, who had just started a master's program at Georgetown, was sending me articles out of a book that I didn't know what it was. And I love the articles. Turns out I work with Healthcare Authority, and it's that very same book, The Leadership Equation. And that's what we're trying to do at the Healthcare Authority and throughout networks in mental health nationwide. That's the ideal. I looked at that and said, man, this is absolutely incredible. That's what I've been trying to do ever since Alicia died. However, next slide, please.
All right, everybody. Looks like Ace is having a little bit of technology issues and is frozen. So we're working on getting him back up and running in the presentation. So hopefully that shouldn't take us all too long. Hopefully you're already learning some things and are finding this valuable. As a reminder, the chat is there to drop those questions in. Ace will join us back, and then later this evening we'll be able to answer those questions and have a little bit more conversation. So we're going to hang out. I apologize for the issue, but hopefully we should be able to resolve that here in, shortly. So if you give us just a few minutes and hang tight with us, we'll be right back with Ace hopefully soon. All right, everybody, the technology seems to be failing us this evening, but that's okay because we have a plan B. Waiting in the wings, we had Paul Davis from the Washington State Healthcare Authority. And while ACE is working to get technology back up and running, Paul's going to pick up the presentation. And so I'm going to pass it over to Paul to continue on where we left off. Thanks, Paul.
Hi, folks. Can you hear me all right?
Yep, we got you, Paul.
Great. So let me pick up to back what Ace was talking about with systems of care. Ace and I have worked pretty closely together for a while, so I don't know everything that Ace does, but I know some of the things. And the systems of care stuff is, I think, pretty important. We think about all of the different disjointed efforts that we've got in trying to get help. If you've ever tried to get help, you understand that. And the point of a systems of care approach is to make getting help more easy and accessible than what it has been. So as you know, the slide up here, as he's talking about, all of these things are kind of the mess that the current systems of care creates for us. And what we want to try and do is make it so that when you need help, you're able to access that without you know, putting yourself in an even worse place than where you were started. So let's go to the next slide, if that's okay, Cato. This one is a tough one for me to look at. I've known Ace just for a few years, and so I've met his daughters that he did not lose. This is a picture of his daughter that he did lose, and it just hurts me to see that. I've got a couple of sons myself, and I know the love that I have for my sons. And you know, looking at an innocent little girl like that, and recognizing that the loss of a person, of any person, is just tragic, and it's the thing that motivates us to do what we're trying to do. So let's go to the next slide, Cato. So as he was reading before, in my opinion, that should not be a reality in family faces when a loved one suffers from mental illness. For several years, I've been hoping to change the existing reality by offering help to an individual. These are the things that ACE has really been trying to focus on, is so that when people face these challenges, that they're able to do that in a dignified and cohesive way, rather than a chaotic way that actually creates even more problems for the person trying to get help. Let's move on to the next slide. Not a surprise to anybody that suicide is extremely complex. When we try and look for a simple explanation for suicide, we're going to be disappointed, and frankly, we're going to be wrong. And we want to know what caused the person to take their own life, and it's generally not just one thing. It can be, you know, depression was a contributing factor. It could be that anxiety is a contributing factor. It could be a number of other things that could contribute, and it's typically not just one thing that creates that place where somebody has those thoughts and behaviors, and that leads to bad outcomes, where it could be a suicide attempt or a completed suicide and a death by suicide. And there are lots of risk factors. Some of those are health, some of them are the environment that people live in, and some of them are history themselves. You know, I think if people have experienced health problems, you recognize that that puts you in a very difficult place. If you're in a difficult environment, that can make things tough. And your own history of what's happened can also be things that contribute to the increased likelihood of somebody having suicidal thoughts and behaviors. And let's take a look at some of those, Cato. Here's some that we know are clearly risk factors for suicidal thoughts and behavior. If somebody experiences depression, not a surprise that those people are going to be more likely to have suicidal thoughts and behavior. Anxiety, some of these other mental health conditions, bipolar disorder, thought disorder, you know, schizophrenic schizophrenia and all the related things like that, and personality disorders, which are actually, I think, not a thing anymore under the new DSM. It's probably something that we cured just by getting rid of the category. But when we think of those kind of categories of people that have the long-standing internal frustrations that we used to call borderline or antisocial personality disorders, conduct disorder, all psychiatric disorders and psychotic symptoms in the context of any of those disorders. And when people have substance use disorders, then it increases the likelihood of exacerbating some of the mental health conditions, and many times taking away some of the brakes on behavior that would keep you alive in the first place. So if somebody is drinking or using substances, it's frequently more likely that they're going to act out on impulse in a way that they wouldn't if they weren't using substances. And there are many chronic health conditions, including pain, that make things worse. And I think we list some of those on the next slide if we want to take a look at that. Some of those that we know put people at higher risk include these that are listed: epilepsy, tumors, Huntington's, Alzheimer's, multiple sclerosis, spinal cord injuries. I've got personal experience with people that have had some of these things. One that's not listed here that I had a lot of experience with, my father had Parkinson's disease. I was telling Ace earlier today that several years ago, I went down to Dad's house, and Dad used to be a hunter and he had a gun. And I said, Dad, you're not going hunting anytime soon. It would be okay if I took the gun. And we talked about how his Parkinson's had really manifested itself in the way of having very serious depression and suicidal thoughts. And so he let me take his gun, and we just had that conversation. And I still have it to this point. We lost my dad from Parkinson's a couple of years ago, but we didn't lose him from suicide. And so that was one of the things that came up in my mind when I saw this list: traumatic brain injuries, cancers, all those autoimmune kind of diseases. You think about having those, and one of the common things is these things are chronic. They just go on and on and on, and it can be really easy to lose hope. And when we think about both these diseases and those mental health disorders too, I used to work in a place that was called an adolescent day treatment center. So we cared for some kids that really had some tough things going on. And it was really interesting when we got asking the kids, what kind of suicidal thoughts they were having, and compared it to the seriousness of their mental health conditions. There wasn't a one-to-one correlation. Sometimes kids that had very, very serious stuff going on didn't struggle as much with suicidal thoughts and behavior as people that you would say, well, it doesn't seem like that's as serious of a condition. But the one thing that seemed to really be the common denominator was that if somebody was losing hope, then we got very worried, regardless of what their condition was. If they just felt like, gosh, this is just never going to get better, and I'm really losing hope, then that's a real concern. When people lose hope, regardless of what kind of experience they're having, then that puts an awful lot of concern in the heads of those of us that are trying to get help. And I'm sure that you guys on the line have probably experienced similar thing. So let's move on to the next slide there. Here's some environmental ones. And these are not a surprise. When people experience a death of somebody that's close to them, a divorce or a job loss, and prolonged stress factors that can be things like harassment, bullying, relationship problems. And these can be even intergenerational when we think of people that have experienced intergenerational stresses because of race or social and economic factors. Those are real risk factors. Clearly, having access to lethal means, including firearms and drugs and things like that, can increase the likelihood of somebody acting out and actually acting on the impulse to do something that could harm themselves. And sometimes just being exposed to somebody else's suicide can kind of actually create a higher likelihood that somebody else would act in a similar way. We know that when there is a suicide in a school, we got to be careful. And that's why it's important that we act appropriately, because not just everything we do decreases risk. And there is always the chance that the things we do can increase risk. Asking about, somebody about their own thoughts is not one of those things, but there are things that can increase the likelihood of people acting out. And that's, you know, what he's calling the contagion or the copycat influence. Let's go on to the next one. So here's what ACE is talking about with contagion. That's the process in which the death by suicide of one individual influences and increases the likelihood of others acting in a similar way. Exposure, sometimes it can be personal association, sometimes it can be somebody that you don't even know, but you know them because of the media reports, and both can increase the likelihood of suicidal behavior among somebody else. And it's why it's super important that we work with media outlets and people that are telling the stories to do it in a really responsible way, because we don't want to increase the likelihood of contagion and other people's suicidal behavior just because of the way we're reporting it. Good intentions don't always lead to good outcomes. Good outcomes come because of well thought and you know, science-based interventions, and those are things that we want to kind of be paying close attention to. And you'll see here that the Centers for Disease Control has some guidance on that. You know, let's move on to the next slide. Here's some more historical kinds of risk factors. A prior history of suicidal behavior puts people at a higher risk in the future. And so it's why, you know, as a mental health professional, we take it very serious if we see past suicidal thoughts and especially behavior. If somebody has made, you know, cutting motions, that's a concern. Even if it was kind of superficial, it kind of gets to the place where somebody may be practicing something that becomes easier over time. And, you know, if you're holding a gun to your head, that can be a kind of practice that can be very lethal in the future. So if we've got a history of that kind of behavior in the past, or, you know, standing on a bridge, those are the kind of things that we worry about, because it's that history of previous suicidal behavior that can increase the likelihood of it happening in the future. A family history of suicidal attempts also puts somebody to higher risk. And as we've talked about, you know, suicidal behavior from friends, that's a form of contagion that we can worry about. And as we've previously discussed too, if somebody has a history of substance use, it decreases impulse control, and it makes it more likely that they're going to act in an impulsive way. And of course, an impulsive action with lethal means doesn't have a way of recovering in some cases. And if people are acting frequently aggressively or antisocially, you know, hurting other people, sometimes they'll hurt themselves too. And this is a concern right now. I mean, we haven't talked about it too much, but we know that we've been locked up for the last 6 months, many of us, and that isolation can be a risk factor. We know that the stresses that we've experienced from COVID and all of the related things, people losing their jobs, people losing income, people being isolated, people not being able to have the kind of social interactions they have, those are things that put us at a higher risk. And so these are things that we're very concerned about at this point. Can we go to the next slide? I think ACE talks about ACEs, and we're not talking about ACE Bulger, we're talking about the ACEs that really are associated with trauma in the past. And there's lots of information about ACEs, and it's important to recognize that these early traumatic events impact people in a very serious way, and we don't want to ignore that. Let's go to the next slide. Depression. Depression, you know, and I expect many of you understand this, but I'll say what's maybe obvious to some of you. It took me a long time to understand that depression as a clinical thing is different than feeling down because something bad happened. If somebody experiences depression, it's not necessarily because somebody had a bad thing happen. If we lose a friend, it's very probably healthy and typical to feel depressed because of the loss of that person. Or, you know, we're at the end of the summer and tomorrow it's going to rain, and it's going to rain for a week. It would be fairly typical for me to be depressed because of that. And I know that in my life, that's how it works. I spend the summers going jet skiing and, you know, and out on the lake. And so I feel some level of depression when something like that happens. Those are typical things that we can expect, and they're experiences that we can expect. There is also a clinical depression that can come across just because of how our brain is working, and there may not be a triggering event And I think Ace may tell you that that was some of the things that he was really struggling with his daughters. How in the world did it happen that my sweet young person that I've lived with for so long is now acting in a way that I don't understand? And many times those are chemical things that happen in the brain, and not necessarily just because of a triggering event. It can be a triggering event, but it doesn't have to be. And if we're looking for somebody only to have depression or anxiety because of something that we can see on the outside, we're missing an important thing. And what causes those chemical imbalances? Sometimes it's nutrition, sometimes it's hormonal imbalances, as he's noting here. Sometimes it can be exposure to toxic substances, and sometimes it's just we don't know. But one of the things we do know pretty clearly, and this has been shown very easily through brain scans, is that people that have depression and anxiety show different outcomes in their PET scans and other kinds of scans we can do with the brain. We see lower levels of dopamine activity for people with depression and anxiety. So we kind of understand that's one of the things that may be going on, is they may have lower levels of specific neurotransmitters. Let's take a look at the next slide there, Cato. So how do we address that? These are some things that Ace has a lot more experience than I do, and I'm probably not going to get too much into it because it's not an area of expertise for my experience in training. But we do know that there are a specific list of things that he's got listed here, and I'll ask him to address it if we're able to get him back again. And let's go on to the next slide, Cato. Here is a slide that he's got about the brain, and I think we were going to actually show this one, if I remember right, that this link was something we were going to hit and actually show you what it looked like. Are we able to do that? I'm not sure if we're able to actually show, but I think that was the plan in this slide deck, was to actually hit on the link and show what it went to. If not, let's go on to the next slide. So neurotransmitters are essentially, we can think about each brain cell as kind of a little reservoir of chemicals, and those chemicals send messages, and those chemicals are called neurotransmitters, or things like dopamine and acetylcholine and things like that. And there is a process that happens that he's got listed here. One of the key parts that we know is that these neurotransmitters get recycled. So they will go from one neuron to another, and then there's a process of recycling it where it pulls it back up, and that's what we call reuptake. And what we know is that some of the antidepressants that we use, for instance, get involved with the change in how that reuptake happens. And all of this stuff happens at the cellular level, where the chemical is made or synthesized, it gets released, it interacts with the cell next to it, and then it gets reuptaked. And so those are processes that happen. And usually when we have something that's going on with depression or anxiety, it's something, I mean, even the same would be the case with psychosis and thought disorder and things like that. It's frequently because of some changes that have happened or differences that have happened with neurotransmitters and in this cycle. And so there are things that we can do with medicine, and there are also some things we can do just by our own selves. If we're out exercising, that can actually change the way that neurotransmitters are functioning. And oftentimes there's as much we can do by exercising and good diet than than what happens with actually taking medicine. So all of those can be important, and we don't want to kind of downplay any of the parts. Nutrition, exercise, good health, and taking the medicine that actually is helping us are all important components. So here is the medicine. Not a surprise to you that there's a lot of medicine that's advertised, and you'll see here that what we saw in 1988 it was $500 million, and then in 2008 it's $40 billion. When I saw this slide, I said, I'd really like to see what it is now, because I remember that $40 billion in 2008, and I was shocked by it then. And I really would like to know where we are now in terms of manufacturing and marketing pharmaceuticals. It's a lot of money, and sometimes those medicines are super effective, and other times, we hear from people that, especially, I've heard this from people that were taking medicines or for antipsychotic kind of medicines, that it was like putting a glove on, and they actually lost the ability to feel some things. And so, we always, as a doctor that's taking care of those things, they always are asking, what are the side effects, and how's that matching against the effects that you're trying to get? So those are important considerations in pharmaceutical, and I think that's all I'll say about that. I'm going to go to the next one. This is another picture of Ace's daughter when she was older. I had met Ace after he lost his daughter, but I feel a closeness to him and his family, and I've met his other two daughters, and when I was looking at this one, I got to tell you, I got a tear in my eye just thinking about that loss. And the truth is, I would have not met Ace if he didn't have this experience. And Ace is a very close friend and a great colleague. And so that tragedy drew us together, and kind of put us on a path of doing some important work together. Let's go to the next slide. So suicide is super complex, and not everybody that struggles with depression is suicidal, comes from mental illness. It doesn't mean just because somebody has got suicidal behavior that they have mental illness or depression, but it's oftentimes tied. Whatever the cause of it is, stigma is a super powerful thing, and this is something that we really want to address as we're working to try and address it. We know that in the coming months, we're going to probably see an increase when there are tragedies and crises like hurricanes and things like that. There's good data to suggest that it increases the likelihood of suicide, and COVID is going to be one of those. And so we're likely to see it from people that we can kind of see it coming, and sometimes from people that we don't. So we really want to be making sure that we're addressing this issue of stigma. Stigma is an important thing. Our experience has been, especially with young men, they'd much rather tell you that I've got a drug and alcohol problem than that I'm experiencing depression or anxiety, or that I'm thinking about not having the will to live anymore. And sometimes stigma is external and sometimes it's internal, but anything we can do to decrease that stigma is super important, because when the stigma is there, then people don't ask for help and they're left to their own devices, and sometimes the luck of the draw of whether or not they're going to be able to act in a way that this is recoverable or not. You think about some people, they have good reason to worry about it. Saying that you've got a mental illness, it still puts you in a place where you're excluded from some opportunities for work. And so these kinds of things are real, and we need to address both the perceived and the real implications of stigma that happens. Let's go over to the next slide. So there it is. What is stigma? Who is susceptible to suicide? Who is susceptible to depression, anxiety? How do you define mental health? And how about mental illness? That's an important question. We still really struggle with that. We're better at defining illness than we are at health. There's a book called the DSM, the Diagnostic and Statistical Manual. It has every mental illness listed in it. Not one of them in there says, well, what is mental health? It just says what mental illness is. We're much better at deficit definition than we are at strength definition. And we're trying to work on that, but it's something that we're not very good at as a society. And so defining mental health, frankly, is something that as a work group, we still are trying to work out. What do you think about the public perception of depression, suicide, mental illness? What do you think about the misconceptions about suicide or not? these are all things that we hope that you're able to kind of formulate. And I think we're going to have some time to do some questions and answers. But let's go to the next slide and see what we got next for us. Okay, Kato, can we go to the next? There we go. So here's some more about stigma. Mark of disgrace or reproach. It's a perceived or negative attribute that causes someone to devalue or think less of a person. People with mental illness often feel diminished and devalued and fearful because of the negative attitude that society holds towards them. Stigma is devastating to those who are struggling. They often experience attitudes from others as hateful, diminishing, discriminatory, prejudicial, fear-inducing, humiliating, or hurtful. The language that we have sometimes is not intended to stigmatize, but it does. And I have to keep checking myself because back when I went to school, we learned some terms that probably weren't very helpful. And this is true both in the public health world that I used to work in, and it's also true in the behavioral health world that we work in. Using people first language is really important. One of the things that when I was working in tobacco prevention, we initially talked about smokers. And then somebody said, well, why would we want to refer to as a person as a smoker and just refer to them as a kind of behavior? Why wouldn't we want to refer to them as a person who smokes? The same thing is true with a person that has a mental illness. You think about some of the most negative terms that are associated with mental illness. Psycho. That person is a psycho. And really what we're saying is that person is a person with a mental illness. And referring to people as things like psychos and weirdos and things like that has a long history. And it's important that we recognize that our language, if we do person first language, that should help us reduce stigma. We have a person that's got a psychotic disorder rather than a psycho or a psychotic. And hopefully that makes sense to you. So our primary goal is to help prevent the suicides, and we want to bridge the gap. We recognize what is that gap, and sometimes the gap is knowledge, sometimes it is behavior, and we got to figure out what are the ways that we can bridge that gap. Sometimes it's in in the way that we report things, and it goes back to that language. We want to share the concepts of effective reporting. What, who, when, where. And this is what I was talking about. If we're doing a news story, we want to make sure that we're not doing things that are going to make it worse, and we want to make it better. And there are some best practices in terms of how we report. And let's go to the next slide. Okay, so here it is in safe messaging. Let's see if we can pull some things out of here. If we're reporting, we want to make sure that we're not oversimplifying. This is a complex issue, and if we're able to work with somebody that is reporting on it, we want to provide some basic do's and don'ts of how to report on that. It's sensitive, and it puts the media in a tough place, because one of the things I've learned about media is there's an old saying in the media: if it bleeds, it leads. And that's just a real thing. That when media reports things, they typically go for shocking information rather than information that's going to be helpful. And in the world of suicide prevention, that's not useful. We don't want shock. So if we're able to provide some exemplary articles showing this is a good and effective way to present the information, we've got that from Forefront, our friends over at University of Washington. Actually, my good old friend Jennifer Stuber, who used to work on tobacco prevention with me when a long time ago, and had her own experience, and then started at Forefront, has some great information about how suicide can be, I think, really reported in a responsible way. And so I think we've got a link to some of the Forefront's information in the slide deck. So let's look at the next slide. This goes back to our system of care conversation. In a good system of care, every door is the right door. Now, this is something we're working on. It's not easy. I know that in the world of Medicaid, we're working pretty hard to try and make sure that people that are on Medicaid are able to access the services they need without being told you called the wrong person or you contacted the right person, and making every door that somebody looks for help the right door. And you think about somebody that's already struggling, just the anxiety. Well, what if I call the right person and they say no, this is the wrong person to talk to? That's the last thing we want to do when they're struggling with themselves being suicidal, or maybe with a close friend. Let's go to the next slide if we can. So there are some strategies that are really about safe talk. How do we learn about that? And then, our wraparound network relationships. And the next slide. It's safe. And this is a really important thing to recognize. And I've been guilty of this in the past too. I was afraid that somebody might be thinking about suicide, and I thought, well, if I ask them about it, maybe that's going to make them more likely to act out on it. And that's not true. We have a lot of experience now in research that tells us that if somebody's thinking about suicide and we ask them if that's what they're thinking about, it doesn't make them more likely to act. There are some other things that that can make them more likely, but asking them is okay. And so it's all right if you're wondering if somebody is struggling with that, saying, are you thinking about your life's not worth it anymore? And just have that conversation, listen carefully. It's might be a little difficult, but it's important to not overreact when you hear that, yeah, somebody is thinking about it. Now, the truth is, when I look at the population data, 22% of 10th graders in Washington State thought about suicide in the last 6 months. Almost, that's an awful lot. And if that's the case, we need to normalize that conversation. While it's not particularly healthy to have those thoughts, it's not all that abnormal either. So if somebody is having thoughts about, I thought about life isn't worth it anymore, it's important that we listen to that and say, it's got to hurt. And let's talk about it. Let's see if we can get you some help. And you want to keep them safe, and you want to keep yourself safe. And let's see what else we got here. Miss, dismiss, avoid. Those are things that I think I'd let Ace talk about the specifics of these specific concepts. And let's go to the next slide. We want to look for the warning signs, want to empathize and listen. And remember, there's a difference between empathy and sympathy. Empathy says that I can understand the same feelings that other people are having. I don't have to feel those same things. That's typically what sympathy is. So when we're listening to somebody, it's important to empathize, but you don't have to feel the same thing that they're feeling about them. And we can ask directly about suicide. And it is important to remove the dangers. I was telling you before about my own father when he had Parkinson's, and we had the conversation, and it was clear that Dad was thinking about life wasn't worth it anymore, and I knew he had a gun, and I just said, is it okay if I take your gun home with me, Dad? I don't think you'll need it. And those can be difficult conversations, but they're really, really important. If you got somebody and you know that they're at risk of a stabbing or things like that, you got to take the scissors away and you say, look, I know this is uncomfortable, but let's lock those up for right now, just so everybody's safe. And those are not easy conversations to have. I've had those with people, and they're tough, and I've coached other people through them. But it's really important to remove the dangers that we know are going to be a potential problem. And then after that, we want to make sure that we're seeking the right resources for them. And that's tough. Getting a hold of the right resources is a complex thing that is not as easy as it should be. And oftentimes it's dictated by insurance rather than by what would be best. But, trying to get people the help is really important. And let's look at the next slide. So 1 in 5 people will experience some kind of psychological issue, and most of them are before the age of 25. And 1 million suicides per year, that's more than all the military battles of the worldwide in a given year. It's a lot of people that we lose every year. And we do expect, and we've been told this from Department of Health clear back in April, it said, watch out for the fall because that's typically when we would expect an increase in suicidal behavior. So it's something we've kind of been bracing ourselves for, and we're expecting it to hit about now. You know, we're at the end of September, and you know, the first day of fall has arrived, and so this is a place we got to worry about. And let's move on to the next slide. It's difficult to keep people alive, and that's a heavy burden, and it can be super taxing. We know that it's tough. And if you're that person that's you know, living or close to somebody that's really struggling with you know, those feelings of not wanting to live anymore, and you know, maybe active suicidal behavior, that's really hard on you. You got to make sure you're taking care of yourself, and that allows you to take care of other people better. So hope, health, resiliency. As I was mentioning before, hope is a big deal, and we want to be as flexible as we can. We want to make sure that we're giving people a sense of purpose, and then reinforcing that anytime that we can, and making those connections, whether they're big or small. People that are connected are more healthy, and that's not a surprise. And let's move on. Let's go to the next slide, Cato. Well, this is something I do know about. WISE is the Wraparound with Intensive Services. I've worked with the Wraparound with Intensive Services program at Healthcare Authority, and actually before that at DSHS for some time. This is for youth under the age of 21 that are Medicaid eligible, and Wraparound is kind of a way of providing the natural supports that are going to take over for formal supports, and wrapping those system of supports around a person. And so WISE is you know, kind of for the folks that are really struggling the most. There are other outpatient services that are available too. So WISE is not the only place, but we want to connect people with the right level of services. One of the things that we really try and do with WISE is keep people from being institutionalized. We don't want them to go into a hospital if we don't have to do that. We don't want them to go to jail if we don't have to do that. And you know, having been in a hospital with a family member that was trying to access it, and watch them sitting in a cell for 12 hours before they could go anywhere, those are important things to avoid anytime we can. So we want to avoid those institutional things. When somebody is ready for help, we don't want to punish them by locking them up. And let's move on to the next slide. Epigenetics. This is something Ace is probably going to talk quite a bit about. What I will say about it, it's really interesting. And what it's saying is that your gene sequence doesn't tell everything. And that's not a surprise. We have twin studies, identical twin studies. And, you know, you think about some things that are genetic, they don't always show up in both twins. So sometimes what happens is those genes get turned on or off based on what happened in that person's life, and sometimes even in the womb. So the genetic sequence that happens and what genes get turned off and on can happen and impact people 2 generations down the line. And mental illnesses and disorders sometimes can be influenced with thinking more and more about not just genetics and not just the way that gene sequence is there, but which ones are turned on and off. And this can be, you know, from toxic exposures or from nutrition imbalances. It probably could even be from, you know, lifestyle choices like exercise. Let's move on. And these are things that I'm not prepared to address. Ace would have to talk about them. but we do know, that epigenetics is tied to mental health, and mental health is tied to genetics, and that includes not just ATGC, but which of those gets turned on, and that's really what epigenetics is about. Neurotransmitter can certainly be a part of that too. And I don't want to get any deeper than that because it's not my area of expertise. So let's go on to the next slide. So this is some information that ACE had, from Dr. Kuhn. And again, I think you've got the slides and you will be able to read this. And I'm not prepared to go into really anything more than what is there. And so I won't just read it, but I will let you folks read it, and you're welcome to follow up if you got some specific questions. So let's move on. So again, epigenetics, it's, probably has a lot to do with what's, how genes get expressed. And the truth is, this is an emerging area of research. I know that for epigenetics, I was at a conference just a few years ago, and this was in public health, and the public health directors were there, and they argued, about the role of epigenetics and how things are going to impact the health of people. And so I don't know that we have complete agreement on it, but it's very clear that it has an important role to play, and that's going to become clearer over time. What's an implicit memory? I think some of the things that we know about is that adverse childhood experiences oftentimes happen before the age of 2. And those experiences don't have a way for you to put words to them, but that doesn't mean they're not real. And so if something bad happens to you in that first couple of years of life, it's been my experience and many other people's experience that kids really struggle with that for a long time because they don't have a way to kind of process that, but it's still there. And that can be, from some of that implicit memory. And if a person experiences early childhood experiences before they really have even verbal language to express it, that can be really tough. Let's go to the next one. And, here's some more information that, again, it's not my area of expertise, and this is information I think that I would probably be best to let ACE address. But I, totally agree with him that implicit memories oftentimes can shape our beliefs and expectations. Just because we don't put things into words doesn't mean they're not real, and that don't have really strong influence on our attitudes, beliefs, and behaviors. So explicit memory, oftentimes we're going to use those memories and integrate them. And, you think about if you experience a trauma, is it better to be able to explicitly put that into place? I think these are things that we're still trying to work out, and I am not the world's best expert at trauma, but, we know that all those things are going to be influencing, somebody's overall experience. And let's go to the next slide. And again, this is stuff that I think ACE is really much better to address than I am. I have some experience with ACE, but these are places where he's got a lot of training that I don't have. So let's go on to the next slide, if that's okay. Biochemical individuality, not a surprise that we are all very different, and we know that it doesn't take much of a change. Everybody is very different, and so even among identical twins, as we mentioned, there can be significant difference from one to another, because we, not only epigenetics, but even some of the stuff we know now is just by our microbiome, all of the microbes and and bugs in our skin and in our gut and in our brain, all those things impact us. And so we have an awful lot of individuality. We're not pre-programmed to just live out our lives with A, T, C's, and G's of our genetics. Let's move on. And I think this is a level of detail that I'm not prepared to get into. I think I'd have to defer to Ace for that. Let's take a look at the next slide. Okay, so nutrients. Chemical imbalances can't be loved away, and that's an important key takeaway from this. If somebody has got that, we can be supportive of it, but it doesn't mean that that imbalance disappears just because we're supportive. Whether that is from an epigenetic change, from it's a toxic shock, if there is some kind of neurochemical imbalance, that's going to have a real impact that isn't something that we can just change with love and support. Let's go to the next slide. So here's the key concepts. This is complex stuff. It's important that we integrate all the information we have. We've got to decrease stigma so that people can ask for help and receive it in a way that's useful. We look for resilience among people that are struggling. Many people have more resilience than any of us could guess, and we don't want to underestimate that resilience. Epigenetics are super important, not just genetics, but how those genes get turned off and on can sometimes happen even when we were in the womb, and sometimes it's from other experiences. We both have implicit and explicit memories. The resources are available, and then there are a lot of practical strategies. And let's go to the next slide. The transformative process. These are kind of the things that I think the processes you think about. Let's go. Hold on, let go, take on, move on. These are kind of just different processes that in stages that we can go on. And let's move on to the next slide. So here's some resources that we've got that we'd mentioned, the National Suicide Prevention Lifeline. One of the things that's a struggle is that there are, I think, 35 different county crisis lines to call, and that can be confusing. But if you do the 1-800-273-TALK, that should be a place where that if somebody is needs some help with suicide, that they should be able to go and be able to be referred to the right folks. There's several books that Ace has here that he can, that you're welcome to look at, and I think we might have some more on the next page too. Oh, I guess that was all of them. So this is Ace's two daughters, and I did get a chance to meet his daughter. I've been over to his house a couple of times, and they're great folks. And is that our last slide? There's his daughter. She's the one in DC. And that's his two daughters putting up the Christmas tree. He drugged that in from outside the house last Christmas, and I remember I was over at his house just before that happened. I think, yeah, I was there right about when that happened, and they were there putting it up, and they're great folks. And that's an important thing to do. Is he did lose a daughter, and he still got his family. That he's got his two daughters that are still there, and that's an important message that he wanted to share. Is that when we lose somebody, it's devastating and it's really tough. And there continue to be relationships we have, and we want to move on in a meaningful way. Is that our last slide? And there they are again. So I think this is the part where we hope to have some questions and answers. Was that right, Nate?
Yeah, I think that's where we're going to try to transition to that now. So thanks, Paul, for jumping in. We didn't prepare you for having to give ACE's presentation, and I know this isn't your main area of expertise, but we do appreciate you doing your best to present the information as well as you can. And so, as a reminder to everybody, this is an opportunity to put some questions in the chat box. We're going to gather those over the next couple minutes, and Paul's going to answer a handful if we have time. I would also want to remind everyone that interwoven this presentation was a lot about Ace's story and his family's story and the effects that suicide has had on his family. And so in the next couple of days, he's going to record that his story, as well as answer some of the questions in the chat box and provide some additional information on some of the slides that were presented tonight. And so we're going to record that, and we're going to post that alongside this presentation. So you're going to be able to get the slides from tonight, as well as ACE's additional kind of presentation that we're going to put together since he wasn't able to get back on here with us. So you can look for that sometime in the next couple of days on the YMCA of Greater Seattle website, is where we're posting the transcripts of our conversations. So as questions come in, Paul, could you, since folks didn't get a chance to meet you, you just jumped right in and helped us out. Can you give us maybe a little bit of your background, where we know you work for the Washington State Healthcare Authority, what you do there, and a little bit of that as questions come in and we can prepare those.
Sure. So I do work for the Healthcare Authority Division of Behavioral Health, and work in the Children's Mental Behavioral Health program. Mostly work with the WISE program. Also work with take care of some other things that get thrown at me as needed. Been increasingly involved with infant mental health and now more with developmental disabilities and autism too. So those are some areas that I'm still learning about, but most of my work has been with wraparound with intensive services.
Awesome. Yeah. Thank you again for just being so flexible this evening and helping us out by walking us through the presentation. So we have a few minutes here at the end. So we have a couple of questions queued up. So first one being, and I think this is something that you'll be able to really speak to, what is the most rewarding part of speaking up on these issues? What does that mean to you as you have the opportunity to have these types of platforms?
It was in 2000 when I moved from working in at a clinic at adolescent day treatment to more of the public behavioral health world, and became familiar with the Healthy Youth Survey and saw the data that said that like 1 in 5 10th graders is considered suicide. And that was back in 2000, and it was very shocking to me then. And I felt like that's something I just can't let go. We've got to improve that, and we have not improved it. And anything we can do to make that better, I think, is just really something that I'm motivated to do. I, like many of the rest of you, have experienced somebody that I know that we lost from suicide, and one is too many. We don't want any people that we've lost to suicide, and anything we can do to decrease and eliminate that is just super important to me. And as I got to know Ace and his story, it was really motivating to me. And it continues to motivate me, and I know he's motivated in a similar way.
Yeah, awesome. Thanks for sharing that. For those who are on tonight and are listening and watching, and they're saying to themselves, "What's the one thing or the first thing I can do to help somebody?" What advice would you give them as the first kind of step?
I think what Ace had put in the slides. It's okay to ask, and sometimes it's uncomfortable. But it's okay to ask and have that conversation, and it's super important because not everybody is going to tell you, and they're more likely to tell you if you ask them. If you ask it in a way that's not judgmental, and just say, "Look, I know that this is maybe you've had some tough times. How you feeling? Are you still feeling like life is worthwhile?" You got to ask it in your own way, but asking the question is really critical because people oftentimes aren't going to tell you if you don't ask.
Yeah, that's great advice. The next question, and maybe I can broaden it slightly. how do you help someone find a counselor covered under the Apple Care and who matches their needs? So maybe a little broader to just how do you match someone's need to a counselor as they're trying to work through that process? What's some advice you'd have?
Sure, and that's this is a frustrating thing, is it is so insurance dependent, and so you kind of have to know what their coverage is, and for many people it's Apple Health. For the kids, it's about half the population, and sometimes it's SEB or PEB, or the public employer or school employee. Sometimes it's somebody like Boeing or something like that, and so you kind of have to look at what their insurance covers. And that's the reality of it. There are places, if you're with Apple Health, I actually have more experience with them. So if you're with Amerigroup, it's got a number there. You should be able to call that number, and they should be able to walk you through how do I get help, based on where I live. And so that insurance company actually is a pretty good starting place. It's been my experience that that's probably the quickest route.
Great. Yeah, insurance is such the driver for so many of these things, and it's creates sometimes more barriers than any one of us would like. We only have a minute or two left on our time here. Paul, is there anything else you'd like to share with the audience this evening? Whether it's addressing any of the slides that were presented, or something else that maybe wasn't on the slides that you want to make sure folks have an opportunity to hear.
I apologize that I'm not Ace. He has some experience and training that I do not have. And so there's a number of things that he had in there that you may have questions about, and don't hesitate to shoot him an email. I think some people are asking, is his coaching, is that a free thing? And I'm pretty sure that, that's something that he does as a professional thing, but I know that he's very interested in answering people's basic questions. So if you got some questions about some of those slides, shoot him an email and he should be able to respond to your question.
Yeah, thanks again so much for just again stepping in and helping us with our technology issues as we weren't able to get Ace back on the call this evening. So just as a reminder, again, if you keep putting messages, questions into the chat, we are holding those questions. The last of our webinar series is going to be pretty much all Q&A, where we're gathering all of the questions that didn't get answered in the time that we had. And trying to bunch those together and have kind of a ending cap to our webinar series that's just mainly Q&A. So feel free to keep putting those in there, even though we didn't get to a lot of them this evening. As I said before, Ace will be recording another event this coming week, and we'll be able to post that back out. So I'd look for that coming in the next week or so. If you want to learn more about what the Y does through our Social Impact Center, you can see the website on the screen. So please click on that and check out the services that the Y provides to the community. And if you're looking how can you support the Y, as we're doing a variety of different programs throughout King County and the greater Seattle region, you can also find ways to do that as well. The next webinar that we have is going to be this coming Thursday. By Namni East Side, so please check that out. You can again find the link to register and get the link for the webinar on our website, and so that's our next series webinar. So again, thank you so much for being here this evening and sticking with us through our technology challenges. Again, a big thank you to Paul for stepping in and helping us while Ace had his technology issues. And Ace for putting the work together and presenting information and being able to spend more time in the next couple of days to help clarify some of that and answer some of your questions. So again, thanks everybody for being here this evening. I hope you've enjoyed the information that was presented, and I look forward to seeing everybody on Thursday or at one of our upcoming webinars. Have a good evening.